Kia ora koutou, good afternoon everyone. It's very nice to have the opportunity to be here. I work on fever in the tropics, so it's my goal in the next 10 minutes just to give you an overview of that area and to acknowledge colleagues who have contributed to the work. So this is a typical outpatient clinic waiting area in an African health facility today. You can see the patients are many, healthcare workers are few, many have limited training, and the laboratory services are minimal and in some cases non-existent. And here in this setting, fever is one of the most common presenting complaints of patients coming for care. To illustrate this, this slide shows the occurrence of diarrhea, cough and fever, the major clinical syndromes in low resource areas, among more than 1 million surveyed children aged less than 5 years in low middle income countries. Fever is shown in red, the most common symptom being reported in more than a quarter of children over any 2-week period. And as you can see, fever often occurs with other syndromes like diarrhea and cough, but in any given 2-week period, 7% of all children under 5 have an isolated fever. And unfortunately, a patient with fever poses a diagnostic challenge anywhere in the world, but especially in the tropics where fever is so common. This patient's been admitted to a district hospital, and the temperature chart's shown on the bottom. She's had fever for several days. However, fever is a symptom of many infectious diseases and some non-infectious diseases as well, and these can be very difficult to distinguish accurately from one another by just taking a history and examining the patient. And in low resource areas, as I mentioned, the problem's compounded by limited number of healthcare workers, very high patient volumes, and limited diagnostic services. So it's interesting in this context to see what World Health Organization guidelines have recommended in this situation over the years. The World Health Organization guideline for the treatment of malaria 2006 had this to say for the patient with fever. The signs and symptoms of malaria are non-specific. Malaria is clinically diagnosed mostly on the basis of fever or a history of fever. And this recommendation could be paraphrased as fever in the tropics should be assumed to be malaria and treated as such. And this malaria-focused approach to the patient with fever is incorporated into lots of syndrome-based clinical management guidelines of the World Health Organization, shown here. By following this guidance, healthcare workers in resource-poor areas can classify and triage sick patients into various clinical syndrome categories, such as fever, and find suggestions for appropriate treatments. For example, a child with cough who has difficulty breathing and is found to be breathing fast would be classified as likely having pneumonia and treated with amoxicillin for 5 days. So it was in this context about 25 years ago that I first found myself working at this tertiary referral hospital in northern Tanzania. And my Tanzanian colleagues in the Department of Medicine at the time had identified this as a research question. Why are we seeing bad outcomes among patients with malaria? So one of our early collaborative studies was to systematically look at causes and outcomes of fever at the main hospitals in the town of Moshi where we worked. We looked at healthcare worker admission clinical diagnosis versus high-quality laboratory diagnosis at national and international reference labs, carefully studying 870 hospital admissions using high-standard diagnostics. We found that healthcare workers clinically diagnosed and treated almost 2/3 of patients admitted with fever as malaria, shown in red in this slide. But using high blood smear and malaria rapid diagnostic tests, the standard test for malaria, only 1.6% of patients actually had malaria, also shown in red here. In brief, the major reason that patients with malaria were experiencing bad outcomes was that most of the patients clinically diagnosed with malaria didn't actually have it. And I'll return to this slide later to discuss common non-malaria causes of fever. But first, I'd like to say a little bit more about malaria overdiagnosis and its implications. This graph shows trends in global malaria incidence from 1990 through 2017. in purple, and in sub-Saharan Africa in grey. And as you can see, global malaria incidence has been declining since 2004. And I could show you graphs with similar, if not more marked declines in malaria deaths over the same period. And these heat maps show malaria parasite prevalence. That's the proportion of people in the community carrying malaria parasites. In 2005 in the top panel, and then 2017 in the bottom. The areas in grey are essentially malaria-free. The areas in red, the proportion of the population positive for malaria parasites approaches 100%, whereas parasite prevalence approaches 0 for the areas in blue. You'll see the marked cooling of colours in sub-Saharan Africa between 2005 and 2017. And so if you take this together with the previous slide, the main message here is that the role of malaria as a cause of febrile illness has not only declined substantially over this period, but is also highly heterogeneous and in fact absent and uncommon in large swathes of Africa. So this means that malaria is not only declining, but also that it's a more common cause of fever in some areas than others. And as malaria has declined or is uncommon, the proportion of fevers due to other causes has grown. This slide summarises the results of a study of severely ill paediatric patients hospitalised with fever in northern Tanzania. Here the study team looked at 17,000 hospital admissions, of which 4,500 met study criteria for severe febrile illness and had a malaria film with results confirmed at a reference lab. Of these patients, 46% were malaria slide positive and 54% were malaria slide negative. It's notable that 95% of all patients were treated with intravenous quinine for severe malaria, despite half having a negative malaria film. Furthermore, those without malaria, only about 2/3 received an antibacterial for treatment of common but potentially fatal non-malaria bacterial infections. And so it's perhaps not surprising then that patients admitted to hospital with fever and malaria on your left had a better chance of surviving than those admitted to fever with something other than malaria on your right, with case fatality ratios of 7% in malaria and 12% in the non-malaria group. So our studies, combined with the switch to artemisinin and combination therapy for malaria treatment, contributed to a major change in the World Health Organization guidelines for the treatment of malaria in 2010. The revised recommendation was that antimalarials be prescribed based on the result of a malaria diagnostic test rather than just on the basis of the presence of fever alone. To quote the more recent guideline, prompt parasitological confirmation by microscopy or a rapid test is recommended in all patients suspected of malaria before treatment is started. Treatment solely on the basis of clinical suspicion should only be considered when parasitologic diagnosis isn't accessible. But you could imagine that this new guideline immediately raised a new problem for healthcare workers. What to do with the patient with fever and a negative malaria diagnostic test? When tests for malaria were rolled out, it was quickly found that in many places, the vast majority of patients with fever did not in fact have malaria at all. And for the few patients with a positive test for malaria, the way forward was clear: prescribe an antimalarial. But for the vast majority with a negative test for malaria, healthcare workers without a laboratory are stuck knowing what to do. Without a picture of what the major causes of severe illness with fever are, it's very difficult to know, and this is the question that underlies much of my research. So returning to this foundational study, what major non-malaria causes of fever did we find among inpatients in Tanzania at the time? Well, about half of the fever patients were confirmed to have infections listed here. Notably, healthcare workers never considered or diagnosed most of these causes of non-malaria fever, and many were unfamiliar to them. This foundational study led to streams of work on some of these major non-malaria causes, including typhoid fever, invasive non-typhoidal salmonella disease, and other infections that time doesn't allow me to cover. As well as many bacterial zoonoses like brucellosis, leptospirosis, and Q fever, These are transmitted to people from livestock, rodents and other animals, and are interesting diseases insofar as they have direct health impacts on humans, but also major impacts on the survival, growth and reproductive success of economically important livestock species in communities with many poor livestock keepers who remain dependent on these animals for their economic well-being. So my ongoing research builds on these ideas. I still work on research to describe causes of fever, including the International Multi-Centre Febrile Illness and a broad range of endemicities, or a FEBRE study. But I also work on development of new, accurate and more accessible diagnostic tests for these major non-malaria causes of fever, and we'd very much like to have tests that were as accurate and as accessible as malaria rapid diagnostic tests are today. We work on patient management, including evidence for appropriate empiric antimicrobials for severe febrile illness, and prevention work, including by vaccines for specific causes, including typhoid conjugate vaccines. Time doesn't allow me to thank the many colleagues and individuals who have contributed to this work, but I'm showing this picture because it shows some of the kinds of environments we work in. Here's a pastoralist community in northern Tanzania that dependent on livestock for economic well-being, but also sharing infectious disease problems with these animals. So I'd like to thank the communities we work with, my colleagues across many disciplines and lots of places, the people who have given me an academic home and supported the work, and of course my family who support me in all kinds of other ways as well. So thanks for your attention.